I have no conflicts of interests. Popliteal artery aneurysms are the most common forms of peripheral artery aneurysms, and we should know that 50% will have a bilateral popliteal aneurysms, and that 30 to 40% have a concomitant abdominal aortic aneurysm. The diagnosis is mainly on physical exam. Every patient should be ordered a duplex ultrasound with either a CT angiography or an MR angiography. The indications for treatment are all symptomatic popliteal aneurysms. They should be repaired. Lower extremity ischemia is the most common presenting symptom and occurs secondary to embolization or thrombosis of the popliteal artery, and the symptoms can range from claudication to acute ischemia. Symptoms secondary to compression also necessitate intervention, and rupture is an unusual presentation except in Behçet's cases. Asymptomatic aneurysms more than 2 centimeters should be repaired. Surgery has been the gold standard. The primary objective is to exclude the aneurysm from the circulation while maintaining distal perfusion, either by an arterial bypass with ligation of the popliteal artery proximal and distal to the aneurysm, or an interposition grafting from within the sac. We can use usually we use the medial approach, and the posterior approach is reserved for large saccular aneurysms that are confined to the popliteal space, particularly one with symptoms attributable to compression of the adjacent structures. We should not forget that surgery is associated with wound complications, and there is graft thrombosis. Things changed, and the Society of Vascular Surgery included in its guidelines the endovascular repair for popliteal artery aneurysms. One of the recommendations is that they recommend that patients with severe acute limb ischemia should undergo prompt surgical or endovascular repair with the use of adjunctive surgical thromboembolectomy or pharmacomechanical intervention to maximize tibial outflow with a high grade of evidence. When we look at endovascular repair, not every patient is fit for an endovascular repair. The anatomical selection criteria should include a normal, proximal, and distal landing zones of at least 1.5 centimeter without marked discrepancy in size between the proximal and distal landing zones. Lack of extensive tortuosity, and an aneurysm that is not too large, which would make a stent graft prone to kinking and displacement. The recommendations are usually at least 2 run-off vessels. We can do it with a single run-off vessel, but better results are obtained when there are 2 run-off vessels. The technique is simple. The popliteal artery is crossed by a glide wire and then replaced by a stiff wire, and the covered stent is placed. Mostly it's a Viaban. We don't have the Viaban in Egypt, and we use the Covera stents. Approximately sized balloons are used to ensure an adequate seal, and of importance is to take a picture with the knee bent to ensure the patency of the outflow vessels. This is a case of a popliteal artery aneurysm crossed by the wire, and this is the first stent deployed, and here the second stent is deployed, and this is the final And this is the final result. The results of endovascular treatment with covered stent, they have a good primary patency rate and a good secondary patency rate and a limb salvage rate of 100%. A meta-analysis for the VIA-BAN showed a primary patency rate of 69.4% and a secondary patency rate for 77.4%. Then we come to the superior stent. The principle of flow diversion for aneurysm treatment is well known for the cerebral vasculature. And this has been applied for the popliteal artery aneurysm. And this is a single center study of 23 consecutive patients, which showed a technical success of 100% and freedom from sac enlargement 100% and even aneurysm shrinkage of 68%. And with good primary patency rates, assisted primary patency and secondary patency rates at 24 months. I put this slide because when we talk about the comparison between the endovascular route for the treatment of popliteal aneurysms and the surgery, this entity makes all the problems. These are the patients with a very poor, with a thrombosed popliteal aneurysm and a poor distal runoff. I prefer in these cases to use an endovascular route, catheter-directed intra-arterial thrombolysis followed by an endovascular covered stent. Now, when we compare open versus endovascular, I have to say that the results of open repair and endovascular repair are somewhat dependent on the severity of the patient's symptoms upon presentation, with patients presenting with acute ischemia due to a thrombosed popliteal aneurysm having the worst prognosis. In a review of patients treated with asymptomatic and patients who had that are symptomatic with acute ischemia, there is a marked difference in primary patency and limb salvage rates. Patients who presented with critical limb ischemia had a low 5 years limb salvage rate. If we compare open versus endovascular repair, a retrospective study which showed open repair as compared to endovascular repair, there was no significant difference in the primary patency or in the secondary patency. And of note that the secondary patency in the endovascular group is 100% because of the ease of re-intervention as compared to surgery. In a meta-analysis, the rate of 30-day graft thrombosis and re-intervention were significantly higher in the endovascular repair group, but patients with the endovascular repair had an equal primary patency rates to those who had open repair. No difference in mortality or limb loss in the two groups. The length of stay and the length of procedure were significantly shorter in the endovascular repair group. So in conclusion, Mr. Chairman, hot conclusion. So in conclusion, Mr. Chairman, popliteal artery aneurysms, although rare, may put the affected limb at risk, and symptomatic aneurysm or one larger than 2 centimeters should be considered for repair. Endovascular repair has been shown to decrease the length of stay and wound complications. However, its durability is definitely inferior. The decision regarding open or endovascular repair should be individualized, and the risk and benefits of each should be discussed with the patient. Thank you very much.